morning, friends of WLA. My name is Laura Adjangba, and I'm the president of Women Leaders in Action. Thank you for joining us for the 10th episode of Empowered Women Empower EWE. Today's episode is about diabetes. Our topic for today is No Diabetes, Fight Diabetes. A little bit about WLA. Women Leaders in Action is a 501c3 nonprofit organization based in New Jersey. We are dedicated to empowering women for success through personal and professional development, mentoring, promoting diabetes awareness, and community outreach activities. I always like to start off with a slogan. And for today, it's a quote from Julie Genny. And it says, if you do not make time for wellness, you will be forced to make time for your illness. If you do not make time for your wellness, you will be forced to make time for your illness. By Julie Genny. Our guest for today's event or episode is none other than WLA's very own advisory board member, Dr. Nelson Aluya. Please join me in welcoming Dr. Aluya aboard. I'll say a little bit about Dr. Aluya. I don't know if I can say a little because there's a lot to say about Dr. Aluya. Dr. Aluya is trained in both pediatrics and internal medicine. He's a medical doctor with extensive broad-based training and clinical expertise in over 3 continents. He is currently the Chief Medical Officer of Newark Community Health Center, a federal health qualified center in Newark, New Jersey. Dr. Aluya used to be the former attending physician at Newark Beth Israel Medical Center and an assistant professor of medicine at the New Jersey Medical School, Rutgers University. He was also the medical director of Sinai Acute Rehab Center, the largest rehab center in Essex County, New Jersey. He has led multiple local and international medical missions, providing his expertise and selfless service to low socio-economic groups, economic and socially displaced and migrant families. There's a lot to say about Dr. Aluya, as you can see. And he continues to dedicate his utmost effort to teaching, research to improve healthcare delivery, especially in the areas of diabetes globally. He is helping to build a framework to recognize, educate, and reduce the barriers to healthcare by creating social and political awareness of the debilitating emotional, economic, and the social burden of this disease. More recently, he has championed on a global scale the public awareness, treatment, and management of COVID-19 infection and vaccines awareness. He is a medical advocate, and it is with pleasure that I welcome him to our forum today. Thank you so much.
Well, thank you so much for that warm introduction. Again, like you said, I'm not a stranger to WLA. They've been my standing pedestal for a lot of things that I have achieved and become today globally. So I'm really appreciative of your leadership, my dear sister Laura, and the entire WLA team, and the great work that you've been doing in the community within New Jersey and across as well. I really do appreciate that, and I thank you for that. And again, thank you for the opportunity to be able to speak to our audience this afternoon on an issue that is weighing on each and every one of us on a daily basis, either individually or by relationship. We know or heard somebody who has diabetes at one point of time or the other. And as a professional, almost 66% of patients who come to see me in the clinic have diabetes or diabetes-related disease. So it's a big issue, and especially when it comes to the African-American community or the Black and Brown community, so much worse, and something we need to pay attention to. So it's a pleasure to be here.
Thank you. Dr. Aluya, and for the audience, one of the reasons why WLA in our mission, we chose to focus on diabetes is we were quite concerned and surprised that 50%, statistics show that 50% of people have diabetes and don't even know it. That means they're not even being tested. So we decided that we would try as much as possible to include that in our goals to educate people. So having said that, um, what would you say, Dr. Aluya, is diabetes and how is it diagnosed?
Well, diabetes, I always tell people this. And I'll say it this way, first and foremost. Diabetes is supposed to be new to the Black DNA. I'll give a global perspective. In the 1980s, diabetes was described, if you look up the literature, as Africa was described as a continent without diabetes. In the 80s here, and they estimated just about 800,000 or less people who had diabetes in the African continent. And you and I were born in Ghana and Nigeria, so we grew up there way back at those times when they were talking about this. And even when I finished medical school in Nigeria, we didn't see diabetes that much. The most common diabetes I saw, training and even working, was type 1, which is the one that usually happens in young people. But then today, that has grown exponentially across the globe. So I like to give statistics and I love to give stats because, like I always say, no data, because statistics will give you data, and data would help you to understand the incidence, the severity, and what amount of work that's needed in addressing an issue and how to get the funding. So there's a common saying I always say, no data, no problem. No problem, no funding. No funding, no solution. Meaning, if you don't have the data for it, you don't know if there's a problem or not. And if you don't know if there's a problem, how are you going to solve it? And you need the money to solve it. So you can't seek the money to solving that problem. So, and that's why, particularly in our environment, when I'm in the environment, the Black and Brown community here in the US and across the globe, data is so important. Now, coming on global, before I bring it down to the US, globally, as we speak today, about 540 million people are said to be living with diabetes across the globe. 540, that's over 500 million people living with diabetes. And that number is expected to go up to 1.3 billion by the year 2050. That's just about 30 years from now. So not too long. So that's 1.3 billion people living in that time. Now, where we live right now, the incidence of diabetes here across the globe says to be 6.1 to 6.5%. Now, if you break it down on different areas of the world, the Middle East and North Africa is just about 11%, and that number is expected to go up to about 16.8%. Now, like I said, Africa is a continent that was diagnosed with diabetes. By 2016, when the United Nations or the WHO, the other United Nations, and the CDC recognized diabetes as an epidemic. It is an epidemic. Before that, they didn't think it was an epidemic. But for those of us who were working on the ground, we knew it was a problem. And they eventually recognized as a problem and a problem that needs to be addressed. And then they now say, oh, it's an epidemic. So CDC, WHO, 2016. At that point in time, there were just about 330 billion people living in the world. From then till now, you can imagine 500 and something. That's a huge number. By 2025, it's going to be 700 and something million. By 2050, 1.3 billion. So you can imagine how fast growing that is. Now, Africa in the 80s was about 850. By 2016, it was just about 15 million people. Now, but today it's about 19 million people living with diabetes. So you can imagine that number has grown within those short time. And of course, you and I know that's a gross underestimation because, again, we don't keep data and we don't make the diagnosis. Now, bringing it here to the United States, by 2016, when they said that, there were just about 33 million people who were diagnosed with diabetes in the United States. But by the end of 2022, that number has gone to 37 million people. So you can imagine that number. And at that time, the entity called pre-diabetes, meaning there are people who are between that they're going to end up with diabetes, but because that's an entity that we didn't know about that was inexistent, now we do know. And what that means is from the numbers where we talk about diabetes, usually 7 and above, with or without symptoms, with that's your A1C. A1C is a measure of what your sugar look like 3 months before. So that's how well we can measure diabetes. Now, from 5.7 to about 7.0, we'll say, some people say 6.5 with symptoms, but I use 7. 5.7 to 7, those numbers, people live in that space are considered pre-diabetic. So meaning you're not diagnosed as diabetes, but you're before diabetes, pre-diabetic. And everybody, like I always tell people this, if there's anything you're going to learn from here today, is to know what your diabetes status is. Know what your diabetes status is, because it's important that we all know that, because a lot of us live in the pre-diabetic state. Now, in the US, at that time, 2016, it was said to be 88 million people were pre-diabetic. 88 million. Today, that number has gone to about 92 million people. And what does that mean? It therefore means that within 4 years, about 40% of those people who are living within that age will become diabetic within 4 years. So if you have 92 million people living who are pre-diabetic, in 4 years' time or less, 40% to 42% of them will become diabetic. That's a huge number. You can imagine that exponential, difference. Now, the problem with that is this, that the little changes that occur that make people come with the complications of diabetes, the blindness, the stroke, the heart disease, the kidney disease, those things really do take place in the pre-diabetic stage, not even when you're diabetic. So on the average in this country, it takes about 5 years when somebody is diagnosed as having diabetes to control. And we classify control as people who have diabetes with A1C less than 7. 5 years, that's what it takes. So you
Dr. Aluya, when you say A1C, what does that mean and what is it?
So A1C, like I said, it's a measure of what your diabetes is 3 months before. Now they use that measure because the regular red blood cells that carry oxygen to our cells can also carry sugar. So it's attached to sugar. So we measure the amount of sugar in the red blood cell. And that sugar that is attached to the red blood cell that carries oxygen to all our cells, because all the cells, the brain, everything else thrive on oxygen and sugar. So when we tag, we about 120 days. This is about 3 months. So that's how they use that to measure it. So that's why it's called the A1C. So everybody, whether you're diabetic or you're not, you know what it was A1C is. It's called hemoglobin A1C. That's just the way it is. Not without going too technical. So that's what the measure. So anybody who goes to see their doctor, you need to have your A1C checked to make sure so that you know what your status is, or your diabetes. Whether you're no diabetes, meaning A1C is less than 5.7, or you're pre-diabetic, meaning between 5.7 to about 7, or you are above 7, which makes you diabetic. So that's how it is. Now, coming to the question of, because I needed to get everybody to understand what these things mean so that they will know how best to approach their clinical or health status and ask the right questions when they see their doctor so that they can get them for the diabetes or no diabetes. Because guess what? If you're pre-diabetic, the better for you, because those damages that take place happen in those pre-diabetic states. So it's meaning your A1C is between 5.7 to 7. So if you drink soda, cut away soda, no more. You can't. 2, if you eat a whole lot of carbs and refined sugar, cut away those refined sugar. You can no longer do that. Now, if you're obese and you're not active, then guess what? You have to start getting active. You have to start exercising. Have to start taking steps. So that's the pre-diabetic stage. So, and that's when you're pre-diabetic stage, I would advise between 3 to 4 months, you go get checked often enough, just to make sure that that five going down 5.8 or 6 is now going in the right direction and not in the bad direction, meaning 6, 7 and above. So taking those steps, watching your weight, watching what you eat, watching the amount of sugar you take. If you eat refined sugar, you cut it back. If you're obese or overweight, you have to, exercise. What I tell people is pick a day or two where you go to the park. You go for brisk walking. You understand? It's good again because when you do that, you're moving your muscles. And especially for Black people, I always tell people, Black or brown people, our muscles eat when we move them, period. So moving your muscle helps your muscle, it helps take away the sugar in your blood and reduce the risk of you becoming diabetic. So going to the park once or twice a week is good because then you get exposed to the sun because we're Black and our skin needs the sun. It's good for your vitamin D, which helps you with your immune system. But we also know that good studies have shown that those with high level of vitamin D level, the risk of them becoming diabetic is so much less. So that's why for us as people of color, will be less for us. And that's just the way it is. Because if you look at the incidence of diabetes here in this country, it's about 7 on the average. Now, if you look at the different racial context for the African American or the Black and brown, it's about 10.5. The Spanish is about 9.8, and the what do you call it? The Native American is about 11.5. So it's much higher among the Native American, but it's higher among us who are Black. But then the Caucasian is just about 7.5 as well. So for us, it makes a whole lot of sense that we take active steps to ensuring that we control our sugar, and we make sure those numbers we look at are accurate, and then we follow up with our doctors regularly.
One question that's always asked, Dr. Aluya, people are not sure about or don't know about is the difference between type 1 and type 2 diabetes. So when one says type 1, what does that mean? And when one says type 2, what does that mean?
Right. So again, I'm glad you asked that question because you know what? When we were growing up, the average thing we knew about sugar, because with everything else, we're learning every day about diseases. And as we begin to realize that diabetes has now become an epidemic, so also the type of diabetes and the changes in how it looks like. Now, we knew type 1 and type 2 along with this. So with the type 1, meaning that the insulin in our body is the pancreas. Now, the pancreas is the one that secretes the insulin so that the insulin gets into your blood and the insulin as it moves into the tissue so that the tissue themselves can go through the process of breaking down sugar. As they break down sugar, your body will be able to utilize the energy that comes from the sugar. Now, however, if the pancreas fails, what it means is the pancreas can no longer secrete that insulin that your body needs. And what it means is that your body can no longer utilize the sugar to go into the cells. So the sugar will be circulating in the blood, but now when there's a primary failure of the pancreas, that's what's called type 1. And it's usually younger in people. Sometimes it's genetic, and sometimes it's from disease. Even virus can help, even some chemicals, or even for those who've had chemotherapy or one thing that happens to the pancreas fails and it shuts down. So that's the type 1. And it's usually younger people. And that's why in some people, it runs in some families. I saw a particular family where all the girls, once they get to age 13, only the girls, once they get to age 13, the pancreas shuts down and they all become diabetic. And they had like 7 girls and 3 boys in the family. All 7 girls, once they turn 13, boom, the pancreas shut down. And then they all become diabetic. The boys were affected. So those things do happen. Now, with the type 2, is the pancreas is still there. It's secreting or trying to secrete. However, there's what they call insulin resistance, either from the blood to the cell, means the system help, there are a whole lot of steps, helps the insulin to allow the sugar go into the cell is failed. Either somebody is obese or for some other genetic alteration itself that the sugar cannot go in. But the pancreas is producing, but the sugar cannot go in because there's an increased resistance. Either from some chemicals the body produces or fail to produce. With knowing GLP-1 now and DPP-4, those are all the other elements that we never knew that was happening before that we now know. Those are a little bit of technical. But in type 2, the body is producing insulin, but the insulin cannot get into the tissue or cannot allow the tissue let the sugar go into the tissue. That's the type 2. Now, over the years, over time, we now realize that there's what they call MODY, maturity onset diabetes of the young, meaning usually the type 2, like I said, the type 1 is for younger people, the type 2 is for older people. Now, if you look at the incidence of diabetes, like I said, I gave the global and I gave the, if you look at by age, for the type 2, when the overall incidence is like maybe 10, for certain age, the older you become, that incidence is much higher. So for African Americans, the incidence for people who are age 65 and above, when the general population is about 10, for them it's about 15 to 17. For those 75 and older, it gets up by 20%. So the older you become, the more resistant you have. So the more incidence of sugar in those individuals are higher. Now, then we now have the maturity onset diabetes of the young, meaning they're younger, but they tend to have the type 2. So, and that's what they call the obesity index that became a big issue. But over time, they now realize, oh, no, they removed the nomenclature of the MODY, maturity onset diabetes of the young. Now we now have what's called LADA. Now with the LADA, the latent autoimmune diabetes of the adult, meaning you're an adult, maybe 18 and above, you tend to present like a type 2. So meaning the sugar is producing, the insulin is producing, the pancreas is producing insulin, but there's increased resistance. You could be young, but then you have type 2. So with those people who take tablets, not the insulin one, because the type 1, the treatment for those individuals, because the pancreas has failed completely, so you need insulin replacement. For the type 2, those are the ones who use tablets. Now, with the LADA, it's a new entity that's coming up. You find out that they're young, but they're presenting like type 2. They need tablets. But after type 2 goes on, it becomes type 1. Meaning the insulin is producing, but there's resistance. But as time goes on, the people and then becoming type 1. So these are the changes.
We're having technical difficulties and we just lost our guest, Dr. Nelson Aluya. He will be joining us again shortly. Please bear with us. We are having technical difficulties at this point. So we'll take a brief break and then rejoin again. Thank you so much.
So I was saying that, right. So I was saying with the new type of diabetes that we're having a situation where people who have, it's called LADA, They're skinny, tiny people, and no longer just the obese type, but people who are skinny that present with a type 1, the type 2 initially and eventually end up as type 1. So that's why when some people tell me, oh, doc, I don't want to be on insulin, but they start with the tablet, and over the sugar is not controlled, they have to start them on insulin. So that's what's happening with the that's the type 1 entity called LADA, latent autoimmune diabetes of the adult. Now you also have the other type, which is the gestational diabetes. And that's when individuals who are pregnant, women who are pregnant, because of the state of pregnancy, there's a whole lot of hormone issues, there's a whole lot of auto regulation of sugar and increased resistance. The mother will begin to have some higher level of sugar in the system, and they have diabetes as well. So usually it's temporary, it's uncontrolled, tends to affect the baby. When the baby is within the mother, babies are usually much bigger than usual, and they tend to have problems with the heart, the valves of the heart.
Right. They can also have
Yes.
problems with not just the valves, but with the heart and everything else as well. So that's a big issue when the mother is pregnant and the child has diabetes. Now, with that child, they're usually very big, and when the child is born, they have what they call macrocephaly. They are really big babies.
Dr. Aluya, we've lost you on the volume. Can you repeat that?
So they have problems with large babies.
Mm.
Right. So I said when those
Right. So when those babies are born, they're usually very large babies.
Mm.
You know, let me come off the other one. Let me use my phone. Okay, so you guys can see me better now, right?
Yes, very clearly.
Right. So when those babies are born, they're usually very born and they are big babies. So that can occur where the mothers have problems with delivering the baby vaginally. So they tend to have birth difficult deliveries, and one of the biggest one is shoulder dystocia, because the baby gets stuck within the canal of the mother. So babies are usually 4.5, size when they're born. So it becomes a problem. That's what diabetes can cause with pregnancy. So, but like I said, after the mother has given birth to the baby, things tend to revert backwards to what it usually is. However, for those mothers, the incidence in the lifespan of that mother becoming diabetic is about 25 to 33%. So if a mother has gestational diabetes, depending on the race, the incidence of the mother becoming diabetic is much higher than the average individual. So for Black and brown people, it gets up to like 30 to 33% incidence of becoming diabetic for those individuals. So that's what the different types. So the type 1, type 2, or the LADA, the gestational diabetes, those are the different types of diabetes that we have. So I think you had another question you were asking?
Yes. You mentioned briefly gestational diabetes and what causes that also, but there's no way to prevent that because it's during the gestational period. Is that correct?
Right. So some people go into pregnancy already diabetic. Now for the gestational one, meaning those they are diabetic, they know that, and they go into pregnancy, they're diabetic. For those ones, they have the same, complications or even more as well. For some, the placenta becomes defective, the blood flow to placenta, which can affect the baby. Those ones are well known. Now, for those who are not diabetic, but became diabetic when they're pregnant, yes, those are the things I just talked about. Can you prevent that? Not really, because in pregnancy, you're expected to gain certain amount of weight in pregnancy so that the baby remains healthy and well and get the amount of nutrition that they need to get. However, if the baby is diabetic,
If your mother is diabetic, you have to have a special care. MFM, a maternal-fetal medicine specialist, would tend to get on board. You have to have a good OBGYN who knows diabetes and how to manage it. And they'll do insulin. Back in the days, they used to do just insulin alone without metformin. But now they're adding metformin to the treatment because it's been shown that metformin actually reduces the risk of fetal anomalies that tend to happen and preserves the baby as well. So speak to your OBGYN, and it's a collaborative effort between your OBGYN, your internal medicine people, and your maternal fetal specialist. So that you have a healthy delivery of a normal baby, and you have no complications, whether the mother or the child.
Okay. Okay. Aluya, as the old adage goes, knowledge is power. With the rising statistics for diabetes, the number of people going up and up, what are we doing as a population wrong? And what do we need to be doing right? You've mentioned some ways to check and make sure, but when we go for our yearly medicals, unless we ask for it, is the doctor, does the doctor know to check for that because there's a rising, there's the numbers for diabetes are rising, or do we have to specifically ask that checked?
Well, I'll take it this way. I often say, and some of you have heard me talk before, when you're going for your doctor's visit, it's like going to church, period. That's how it has to be. First, you have to look nice, you dress well, because once you walk into your doctor's office, you need to look nice, because then guess what? Just like when you come see your doctor, you don't want your doctor looking scraggy and unkempt and all that. No doctor wants their patient looking scraggy, and no. You have to put in your best. You have to put in your best foot. So you have to prepare the day before, 2 or 3. Because you already have set up an appointment. And before I go into that, look, in all sincerity, let's call a spade a spade. There's no way. And if anybody,
Aluya, we can't hear you.
Oh, okay.
You're saying something important, but we can't hear your volume.
Oh, can you hear me now? Maybe it's again the reception. Can you hear me?
All right. Yes, I can hear you now. Yeah.
Right. So I said this, that people who often set up appointments on an emergency cases to go see their doctor, they're doing disservice to themselves. You cannot be seeing your doctor on an emergency service every time. It is wrong, and you're doing yourself, not just yourself, but your family a disservice. Because if you're not responsible for yourself and for your health, it therefore means you're not truly considering the value and the status of your family, period. That's just the way it is. Because if something happens to you and you end up in the hospital, guess what? Your family will leave everything that they're doing and come see you in the hospital. Who wants to do that? Nobody should be doing that. Because you were hard-headed and you didn't pay attention to your health, and then everybody will have to run to come see you in the hospital? No. But if you set up an appointment, a regular scheduled appointment, you see your doctor will sit and have a talk with you. And everybody, whether you're healthy, you're strong as a bull or whatever, look, you have to have an annual visit once every year. At least once every year. You have to have I always tell people this. We have cars, right? Yes. Do we take our cars for tune-up? Yes, we do. If you can take your car for a tune-up and a service, what's the ultimate service that you need to do for yourself? You have to have a service 1 year at least, because we do that. And some of us have insurance. Well, I'm strong. I don't need to see a doctor. I haven't seen a doctor in 5 years. That's an evidence that you're in good shape? No. That's evidence that you're not taking good care of yourself if you haven't had an annual checkup, period. That's exactly what it means. If you have insurance and you're not checking, then it's wrong. But guess what? Even if you don't have insurances, there are places where you can go where there's a federal health qualified center, like where I head. We have 7 of them in SS County. The Newark Community Health Centers, for those who know, Google it. Type in Newark Community Health Centers. We have centers in Irvington, in East Orange, in Orange, and in 3 places in Newark. You can go there, and you can go there. We'll provide healthcare services at the cost that you can manage to pay, period. because that's what the federal government has put down money for us to take care of you. So some people are, I don't have insurance, so I can't go. No, there are places for you to go, and they're all around. Google it. You can go. And for those who know, tell your family members. If there's anything, reach out to WLA and reach out to Laura. She'll reach out to me and I'll tell you where to go so they can go get healthcare free.
There you go.
Blood work, because we have an arrangement with LabCorp. They'll do where you can do, if you do tests, there's $100 and something, $200, $300 somewhere else. We can do those same tests for you for a whole lot less because we have an arrangement with LabCorp to do those test level at a level that you can afford for you. And even medications as well. We have what they call, there's a 340B, prescription plan that the federal government has set with institutions like ours that we have with the pharmacy. They can get this medication for free for you at relatively dead cheap prices. They're the same medication that work, that everybody's taking, but they'll give it to you for a huge discount because that money has been set aside for people who don't have insurances. So that's what it is. Now, if you don't want to go to all those places, look, call a doctor up, set an appointment, and you can pay $70, $80, $100, which a lot of people can afford because it's your health. We saw what happened with COVID.
Your volume went down again, Dr. Aluya. We're missing, we can't hear you. We're having technical difficulties once again, viewers. We can't hear your volume. We're having difficulties.
Oh, sorry. Okay.
Okay.
Right.
Yeah, much
So,
better.
like I said,
so you mentioned we locked you from COVID. So please go back to COVID.
Oh, okay. I said when the whole world got COVID, the world stopped because the world was sick,
Yes.
right? So you can afford to set $100 at least once a year to go see a doctor if you don't want to go to a federal health qualified center like us, NCAC. You can save $100, go see. Because often enough, we send $200, $300 for families back home. For those of you who are Africans, you can spend $100, $200 for your health. You here who's making the money for people back home? No, you have to do that. So, but like I said, going to see your doctor is like going to church. You have to get prepared. There's an appointment set up. Now you sit back because you are the only person who knows yourself better than anybody else. You know what's bothering you. You know where your pain is. If it's your leg, your head, your back, you know what you can't eat, you can't drink, why you can't sleep, all of those things. You jot them down, your problems. You list them based on priority. What's the one that's most important to you? Number one is your diabetes, or you want to screen for diabetes. Number two is cancer, because guess what? Your brother got diagnosed with cancer. Again, that's another issue with our community. We don't tell each other's diagnosis. Share your medical history with your brother or your sister, because guess what? Whatever is wrong with you, most likely will wrong with your brother. And whatever is wrong with your brother, most likely is wrong with you. If there's a history of cancer in the family, share that history. If it's a blood pressure, if it's kidney problem, share that history with your family member, because you're going to help protect them. We don't do these things, and that's why a lot of us end up with problems. So again, coming back with preparing for your medical checkup, write them down. If you're concerned because your brother got diagnosed with colon cancer, oh, I need to go get screened for colon cancer. If it's a kidney, you need to go get screened. Your brother had a stroke. Why? You write it down. So when you see your doctor, you have that list. 1, 2, 3, 4, 5. Doc, this is what it is. I'm coming for my annual check, because one annual check every year, you're qualified to have 30 minutes with your doctor. 30 minutes is all yours to discuss this issue. Now, in 30 minutes, you'll be shocked. 30 minutes will fly past so quickly. But because you've written down those things down, you'll be like, Doc, okay, he's going to ask you a few questions about your health, your stiff, and what complaints you have. And then you're going to tell them. And then you're like, Doc, these are my concerns. I think my brother got diabetes. I want to get screens called diabetes. Even if you don't tell him, he should know that when he does blood work. Because every 1 year, you have to have blood work. Where they screen for diabetes, for cholesterol, your kidney, to make sure there's no protein in the urine. And then check your blood pressure. If your blood pressure is high, then they're like, okay, either they start your medication right now, or they see maybe because you're anxious, because a lot of people come in, they're really panicking. Nobody wants to see a doctor. Pressure is really high off the roof, especially at the top number. This is the one they call the systolic. Once the systolic is really high up, but the diastolic is normal, you know you're anxious, you're panicking. The doctors will tell me bad news, because I ever have people like, you don't come to the doctor? No, I don't. I said, why? Because they give me bad news. They give me high blood pressure. It's the doctor that gives you high blood pressure. The doctor gives you diabetes. You understand? So they're panicking. But it's our job to say, okay, fine. You came in, the top pressure is high. By the time we speak, we talk and we calm you down. You're all okay. And then we can check the blood pressure again. Now, as a funny joke, one of the reasons we tend to keep people in the office for so long is because when they come in, they're panicking. By the time they panic and settle down, the body's all calmed down. We check the blood pressure. It tends to do better.
So, Dr. Lee, in that case, is it good for the doctors when you walk into the offices to make you wait and relax a little bit before
Yes,
taking
you
the
wait and relax before we check your pressure, because otherwise it's right off the roof, and they can put you on medication that you don't need. So once you calm down, they check again. But even when they check before you see your doctor, by the time you see your doctor, they explain things to you on your karma, your whatever. We can check the blood pressure again and make sure that it's much better. So we make the best informed decision about what to do for you, whether to put your meds or not to put your meds. So those are the steps. Now, again, once you have that minute, that once a year annual with your doctor where you discuss everything, family history, everything you discuss. But because you're prepared, you be able to get the best out of your doctor at any point in time. So, and then they'll do the blood work. But guess what? One of the things, again, that happens in our community, the doctor said to you, okay, we're going to do blood work, we'll check your cholesterol and whatever. You do the blood work, you go away, you don't show up till the next year. That's bad. You're doing yourself a disservice. Anybody who's had blood work, 2 weeks, you have to follow up with your doctor. If the doctor did not give you an appointment, ask for a doctor for 2 weeks appointment. Because you know why? What you're going to do in 2 weeks, you're going to come, switch with your doctor, one-on-one, where at this time around, it may not be 30 minutes anymore, but it's 15 minutes. He's seen the result. He's going to sit and review that blood work with you. Whether you have diabetes, whether you have cholesterol, that's the point of your meeting. Because guess what? A doctor gets hundreds of lab results every day that come in. And he has to sit and review those results and call those people up. If you don't show up, look, some of them may call you, but guess what? God forbid, you don't want to be the one who will fall through the cracks. Because when people fall through the cracks, that's when bad things really happen. So you don't want to be one of those. So you will take responsibility for your own health. So what you do, as you're living, doctor, I need an appointment for 2 weeks, maximum 1 month. But don't do it 1 month, because God forbid something happens. 1 month is way too long. 2 weeks, you set an appointment, you sit with your doctor. If you're clear, you're clear. You go home. You don't have to come back in 1 year unless when you have an issue or you have to discuss a cold or whatever. Then you can come in. And guess what? Look, if you have any concern, family history or something pops up somewhere, it's okay to set an appointment. Come with your doctor and you have discussion. Now, for those who already have diabetes, have medical issues that they're managing, once a year, it's also okay. They can manage your diabetes every 3 months or every 2. Once a year, you set up an appointment again where you get that 30 minutes with your doctor. Everybody, irrespective of what your clinical status is, once a year, the insurance company is mandated to give you once a year annual checkup where they can talk about every other thing as well, including the screening for diabetes, screening for cancer, screening for all of those, including discussing your family history. So it's important. Everybody needs to have a 1 year annual visit, and it's something you need to prepare for. Now, if you're diabetic and they tell you, oh, your A1C is 9, and your goal is to get that A1C less than 7. Anybody who has diabetes has to have an A1C less than 7, period. Because studies have shown that if your A1C is less than 7, The risk of you having stroke is less. The risk of you going blind is less. The risk of you having a heart attack is less. The risk of your kidney failing is less. The risk of you getting amputated is less. And for men, the risk of you having sexual dysfunction is much less too. You know, unfortunately, two of the reasons that bring men to see their doctor is when, hey, they can't perform anymore and they don't know the reason why. Then they have to go see a doctor because they, guess what? You know, it's an issue. And then they're like, oh, then they put me on medication that can affect my manhood. Look, it's better to put you on meds that will control your sugar and control the issue that affect the manhood than anything else. And you can have that frank discussion. If the doctor gives you a medication that affects your manhood or performance, you can set an appointment. Doc, this thing is not agreeing with me because everybody's not the same. Some people eat an egg and they're fine. Other people eat the same egg, they end up in the hospital. Does that mean eggs are bad? No, it's not because the eggs are bad. It's just bad for that individual. So also medications are. So if the medication is not good for you, set an appointment, you follow up and say, Doc, I was taking these meds, but it's not good for me. And your doctor will sit with you and address the issue and put you on another medication. Thank God we live in the US, but not just we live in the times where we have options, different options. And those options are options that you and your doctor can sit with and discuss and have come to terms where you can tell the medicine that will work best for you and protect you. Now, the number one cause of kidney failure in the world, is diabetes, period. There's no double talk. Whether you're Japanese, Chinese, or whatever, the number one cause of kidney failure in the world, and if people end up on dialysis, is diabetes. The number two is high blood pressure. So you can imagine if you have diabetes and high blood pressure, and they're both uncontrolled, you're heading towards diabetes, kidney failure. That's straight up. And unfortunately, I'll give you the statistics on that in this country. Black people constitute about 13, some people say 15% of the population in the United States. But we, Black people, constitute 34% of people who are on dialysis. 34%. You can imagine. So it therefore means there's something wrong. Our incidence of diabetes is higher. We have the social determinants of health and disparities and all that that's affecting us, our kidney failing. But it's not just that. But I'll tell you one thing that is coming new that a lot of us we didn't even know. Look, up till last year, I didn't even know that as well. But we're knowing this and we're learning. We as a people, we carrying a gene. It's called APOL gene. We carry it, especially those of us who are from Africa, West Africa. We carry a gene that increases our risk of ending up on dialysis or kidney failure 10 to 20 times anybody else. Period. There's no double talk about that. If you're in doubt, please look up APOL gene. We're carrying it. The same we carry sickle cell gene, the same way we carry the APOL gene. Just like sickle cell gene, the defect is affecting us to a point where it happened so that we can protect ourselves against malaria. The APOL gene came about, it's relatively new mutation, coming out of West Africa. It's the gene defect happened out of our body trying to protect us from getting the African sleeping sickness. For those who know sleeping sickness, trypanosomiasis. Because our body wanted to protect us from that disease, it created a gene mutation. They call G1, G2 gene mutation. And Black people, unfortunately, carry it, just like we carry the sickle cell gene. 15% of the population in the United States carry it. So look, if you have diabetes and high blood pressure, we don't know if you carry that gene or not. Hopefully we'll be able to get to a point where advocate where we now screen for that gene, because that's one of the things I'm working on right now, so that everybody gets screened and you know if you're carrying the gene. Just like I would tell my child to get screened and know what her genotype is, if she carries the S gene, and if she's going to marry somebody else who also carries the S gene, and say, hey, you are carrying the S gene, your boyfriend or fiancé is carrying the S gene. If you get married, you're going to give birth to a child who most likely will have sickle cell, and we cancel them. It is also time we begin to cancel our people when we screen for that gene so that they don't give birth to a child who has a higher percentage chance, 10 to 20% chance of kidney failure or ending up in dialysis. So that's why it's so important for us as a Black people that we, one, know what our diabetes status is, know what our blood pressure is, and control both. Because inherently, unfortunately, we carry those genes. So that's why it's so important. And we can't overemphasize. It's not just the social determinants of health anymore. These are some of the things we need to begin to pay attention to so that we know how best to take care of ourselves, our community, and handle our business and handle it properly. So that's what I will say when it comes to all of this. Managing, knowing what your status is, managing properly, and making sure that it's all under control so that you can prevent other things from happening.
Dr. Aluya, you've mentioned a lot of important factors to prevent, to make us aware and to prevent the onset of diabetes. But one area I would like you to touch on is the diet. Now, you mentioned already that we need to watch our diet and our sugars and so on. So what would you advocate for, like the 3 meals we have in the day? What would you advocate for breakfast, lunch, and dinner? Because our foods in general tend to be very carb heavy because they're comforting foods. And if you're going through a lot, you're stressing, typically you will be eating comfort foods. So right. What would you advocate? What for you as an expert in this area would be breakfast, lunch, dinner?
Well, I'm very, very practical when I talk about this. Again, I just talked about medication and food. Not everybody eats the same food. We don't. Right. I mean, you're from Ghana. I'm sure you grew up here. Maybe you're eating Western food now. But look, personally, I was born in Nigeria. My DNA is still straight up, straight up African, straight up Nigerian. And though I live here now, but predominantly the kind of food I eat is predominantly Nigerian-based kind of food. And I'll tell you why. Remember when I started, I said Africa was a continent that was what? Described as a continent without diabetes. That's the food. Our food has always been carbon-based, carbohydrate-based for centuries. We didn't have diabetes, right? We did not. Okay. So now we're standing and castigating African food. No, that's what our forefathers ate, and that's what their DNA was coded for, and they live well. It therefore means something happened to the kind of food for those who got here. Some of us got here 20, 30 years ago, but some of us got here 500 years ago. So when I approach that, I approach it in that manner. The people who came here 500 years ago, and over time, 500 years of genetic alteration and modification has changed a whole lot of things. And one of the things that's changed is the way they ate the food that they were prepared here. We know what they call epigenetics. What epigenetics means is the environment that we live in. It's altering, it doesn't change the DNA because you're still Black. What is altering is the way the DNA expresses itself. That's what's called epigenetics. So for those of us who came 500 years ago, the 500 years of living here, of living in a temperate area where winter will be here right now, very soon, and we will not get the sun as much as we will get. And that is the amount of vitamin D that your body will get. And that vitamin D alters the way your immunity responses, it alters the way your bones are formed and strength, it alters the way the risk of diabetes and heart attack, it alters all of those. So it therefore means that those of us who just came in 5, 10, 15, 20 years ago, we're still coded with the African DNA straight up right now and how it affects us. So again, irrespective of what you eat, one, because when we come here, the kind of food that we eat, it's a whole lot different. We eat purified sugar. We drink more soda because now we're in America, oh my God, the food, all those burgers and all those things that we never were looking on TV that we're going to eat. Now we're here. Let's eat all of them straight up. By the time you begin to eat all of those, and then you live in an area where there's winter and you're not getting a whole lot of vitamin D, a whole lot of things are changing. It's affecting you. You begin to look nice and fresh, and your skin begins to pop up, as we say, when they see you from back home, like, oh my God, you're living well, you're living large. It therefore means you're eating good food. Well, all that food that you think you're eating, are they really good for you? And that's one thing that is important. And that's why you need to have that 1 yearly sit down with your doctor who's going to look not just at you physically, but look at your blood level to tell you what's happening to you internally. Because at that point in time, you begin to spill protein in the urine. There's what I call albumin. So again, two things, A1C check, and you ask your doctor, doc, do I have protein in my urine? Because when the kidney is suffering, the first thing is do, it begins to spill. It's like oil. When you're driving your car and then you park your car, you drive off, you see oil on the ground, you know something is wrong. Something is definitely wrong. It shouldn't be like that. The same thing with us. The kidney begin to spill protein. Sometimes it's called albumin. If you ask that, oh, doc, ask your doctor, how do I, please, could you screen me to make sure that my kidney is not spilling small protein? He'll know what you mean, and he'll check out for you. Because if it is, it therefore means your kidney is suffering from pressure or for diabetes or something else. And those things are really important. You understand? So when it comes to diet, the diet that you're used to, you're built on eating, those are the things you still eat. But you make sure they are more natural, increase your fiber, because our food, as we say back home, they're carbohydrate based. But guess what? The carbohydrate based on fiber, natural sugar, not purified sugar. We need to understand your starch, they're natural, right? They're starchy food with fibers, they're big. And that's why when you eat, we have the fiber that pulls the whole thing down, even when we move our bowels. You understand? So our food, when we eat them with soup. And guess what? What kind of soup are they? They're soup with what? Vegetables, right? And those vegetables has a lot of fibers as well. So that's why when we come here, because they don't have those vegetables that we eat back home, what do we eat here? Salad. So we make sure we eat more salad. And back home, when you're sitting by the house, what else do we eat? We eat a lot of oranges. We eat a lot of mangoes. We eat a lot of sugar cane and all that. But guess what? Those are fibers, which are natural what? Natural sugars, not purified sugar. So when we eat back home, in between we make it look like snacks. We eat those things. After that, we eat granuts, we eat peanuts, we eat all those nuts that we eat. Those are the things that we eat back home. But when we come here, we're running from doing overtime to whatever. We're not eating good food. We're eating Burger King and drinking soda. You understand? Those things tend to affect you. So when you come here, the portion that you eat makes a whole lot of difference. If you're going to eat pasta, all right, eat pasta, but look for the whole grain kind of pasta that people eat, not the purified one that you don't even know where they come from. So those are things that are really important. And if when you're in doubt, ask your doctor to send you to go see a nutritionist, because that's what they do. You go see a nutrition will sit with you, plan with you the kind of food you eat, and you tell them, doc, nutritionist, I eat pounded yam. And if they don't know what your pounded yam, and he's going to be your nutrition, he or she better go back and read what pounded yam is and look what it's made of, so that you can have that practical and frank discussion with your nutritionist, and they'll come up with a plan for you and the portion, and those are the things. But more importantly, like I said earlier on, our kind of muscles are different. And when I tell people our kind of muscles are different, somebody looked at me. I said, listen, do you think that Black people, men and women, are the fastest people on earth? Do you think it's by chance? No, it's by genetics. We're built like that. There's a genetic component that made us the fastest people on earth, right? So it therefore means if we are the fastest people on earth and we're genetically built like that, it therefore means our muscle fiber are different from other people, period. There's no double talk about that. So what that means is our kind of muscle, and I'm telling you now, our kind of muscles eat more when we move them. And that's why when a Black man lives a sedentary lifestyle, they come out worse than anybody else. You're not exercising. You're not taking time to go to the park and walk around. You're not moving your you're doing yourself a huge disservice because your muscle type is coded to move. Period. And I'm saying in a very simple, practical way, without ambiguity or technicalities, so that we understand better why this is like that. Because that's how we're coded. And in the future, one of the things we're looking towards is called precision medicine, meaning arranging healthcare practices that is aligned with you based on your race, your socioeconomic status, and based on your genetic makeup. In the future, we will look at one tablet and we see if it's naproxen, Advil, or whatever. We build it down with the genetic code to see which one is better for you, that will better control your blood pressure or better control your pain. And that's what we're heading to. And thank God for AI. We can't forget that these are the things that are popping up down the road that they will help us manage so that we can better know how well to take care of ourselves. But I'll tell you this, as healthcare professionals, for those who are healthcare professionals who are out there listening as well, you and I are the custodians of our health for our communities. We need to be informed. You have to read. You have to read. Things are coming. They're changing the dynamics of what the healthcare system is that's coming in the future. You have to read. You have to read so that you be abreast of what the changes are coming, so that you know how best to provide the services and care for your community. Just like you expect your mechanic to read about your brand new Mercedes-Benz with the AI in it, so that you know so that he can know how to fix your car, so that you will drive. As you drive, your navigation will not take you out to the riverine area, but take you home. That's why this is how practical this is, so that we must know how to best take care of ourselves and our community.
Wow. Very well put together, and thank you so much. Knowledge is power, and we've learned a lot today from Dr. Nelson Aluya. And again, our topic today was no diabetes, fight diabetes. And if you have any questions, please direct them to us through our social media platforms and also through email, info@womenleadersempower.org. And Dr. Aluya, if people want to contact you to get more information, what is the best way to contact you?
Well, I'll say this. You can contact me. I mean, you can look me up on either one of my social handle. I get that all the time, though. You can look me up via social media. You can send me a message through that if you can. But best, you can get through to WLA. Like you just said, send your messages or information through that, and they can reach you through. You can reach me through that as well. Or you can look up NCAC, the Newark Community Health Centers in Newark. If you Google that up, you can, get our number. Is the main number is 973-483-1300. You can, ask for Dr. Aluya at the extension, and they can get through to me like that.
Okay. Before you go, Dr. Aluya, there are some announcements that we would like to make on behalf of Women Leaders in Action. So I would direct that to our Chief of Staff, Ms. Judy Santillas. Please, can you tell us what's coming up on our calendar?
Okay, great. Well, thank you, Dr. Aluya, for this wonderful episode. I have some takeaways from your presentation here. I love share your history. That is something that we're definitely going to take with us, because like you said, if your brother or your sister's not telling you what's going on with them, you won't know what's going to happen to you down the line. So yes, share your history. And I will definitely look up this APOL gene that increase the risk of kidney failure. The more you know, the better you are. What's coming up next with WLA? I would like to extend an invitation to all to join us in person or virtually to walk and raise awareness about diabetes. So the American Diabetes Association and WLA will be stepping out to walk to stop diabetes on September 23rd, 2023. So you can join us in person at the Manasquan Reservoir in Howell, New Jersey. That's at 311 Windler Road, Howell, New Jersey. It's a 5-mile course. So you can either walk 1 mile, walk half a mile, or you can be brave and do the entire 5-mile walk. We will be there. We'll meet you promptly at 8:30 a.m. Our walk will start at 9 a.m. Or you can join us from your home and walk with us virtually. Walk with us in a park near your home, wherever you want. And then you can send us your pics or join us via social media to let us know that you're walking to help support the awareness about diabetes. Again, you can reach out to WLA for additional information. Thank you again, Dr. Aluya, for all this information that you provided. It was very well given. Thank you.
Thank you, my pleasure.
And one more announcement. Thank you so much, Chief of Staff of Women Leaders in Action, Judy Sentilis, much appreciated. And one more announcement before we close. Women Leaders in Action also, we're holding our annual fundraiser and scholarship awards event on November 18th, 2023. It's a Saturday at 8 p.m. at the Hanover Manor. Our theme this year is empowerment through education. For those of us who've joined us before, you know it's a must go-to event. In the past, one of our honorees is Dr. Nelson Aluya, and it was just great to see people come from all over just to see him honored. So we are honoring one of our very own, Dr. Ruby Fayose, pediatrician and public health specialist this year. And our keynote speaker is Mr. Abdulatif Ajani, a CPA and also a partner at Ernst & Young. So please, our tickets are being sold right now. Join us because the fundraiser helps us raise funds to help kids going to college, to give them funds to be able to be successful in life. And we've heard from so many of them, you hear from some of them again at the event, empowerment through education. And one slogan I always mention is, if you think education is expensive, try ignorance and you see the difference. So on behalf of Women Leaders in Action, I would like to thank Dr. Aluya once again. Thank you so much. And our viewers, without you, we would not be here, we would not be able to go this far. The Almighty God for making it possible that we're even here today, healthy enough to be able to talk and present. WLX Executive and Advisory Board members, I would like to acknowledge those who joined us today. Our Chief of Staff, Ms. Judy Sentilis. I see Alex, Mr. Alex James, our Advisory Board member. Thank you, thank you. Ms. Susanna Kangi joined us from Abu Dhabi, but I see the time difference is 8 hours, so she's off to sleep, but she was on briefly, and I thank her. She's one of our ambassadors. My volunteer who always put things together for us, Amy Ramirez, thank you so much. Staff members, you know, and family members who joined, my family, always there, always supporting. I thank you very much. But once again, Dr. Aluya, thank you so much. We approached you at the very last minute, but you're able to do this. We hope you can join us virtually or wherever you are for the walk, because we need you to spread the word about diabetes. It's the killer, and we need to be able to contain it as much as we can. So thank you so much. And please join us again for our next episode, which we will be announcing shortly. But join us most importantly for the walk and for the gala next week. See you there virtually or in person. Thank you so much.
Great. Thank you. My pleasure.